Welcome everybody to this educational seminar hosted by HMS Medical Solutions. My name is Chris Constable. I have the pleasure of being moderator here this evening. And I would like to ask you, before we start, that if you have any questions during the session, please enter them in the questions section of the chat. And we will collect them at the end of the presentation. I should also inform you that this session is being recorded. You have access to this recording after the session. There are some slides during the presentations this evening which contain a lot of information which you might find more convenient to review on the video. So, without further ado, it gives me great pleasure to introduce our two presenters here this evening. We have Professor Bernhard Sattler. He's a board-certified medical physicist, expert in nuclear medicine. He is heading the physics section and vice chair in the Department of Nuclear Medicine at Leipzig, Germany. He has 30 years experience in nuclear medicine and also with an emphasis on radiopharmaceutical dosimetry and hybrid molecular imaging. He's also been teaching in the field and is part of several curricula, medical physics and radiation protection, both nationally in Germany and internationally. And we also have Dr. Jens Kurth here with us this evening, also a medical physicist from the Department of Nuclear Medicine at the University Medical Center Rostock in Germany. Dr. Kurth has been in the field of nuclear medicine for 20 years, and his research focuses primarily on molecular imaging and dosimetry in the context of oncology, theranostics, and related radiation protection aspects. So, without further ado, I hand over to our first speaker, Professor Bernhard Sattler. Thank you.
Thank you, Chris. Thank you, Hermes, for inviting us to give this educational series on dosimetry in Theranostics, and with the second title, The Controverse of Need, Sense and Purpose. And it took us quite a time to find a title like that is not too provocative, but still says what we want to discuss today. First of all, I will give a short introduction on the beauty of dosimetry, what we can do. And then we will go to regulatory need and scientific evidence and guidance. And then Jens will, I will hand over to Jens, and he will show you what is clinical, what is actually the clinical purpose, and where do we really need dosimetry, where is feasible or where not. And at the end, if we still have time, and I hope so, we are interested, of course, in your opinion and your practice. So we will be very quick with our talks, because I think the most of you know the basics and also the beauty of dosimetry. And some of you, if you're physicians, are thinking, do I really need that? And because of that, we will actually want to listen to your opinion and your practice. So, what is the physical and technical availability? We have conditions, of course, the transport of the therapeutic radioligands and the biodistribution, that is pharmacokinetic, blood flow, diffusion, binding, internalizing in cells, tissues, or structures. And then we have, of course, to consider the transport, deposition, effect, impact of radiation energy, and that is actually radiophysics, structural and geometric circumstances and dimensions of the structures we want to irradiate, and the features of the radionuclide, the type of radiation and energy and half-life, and of course radiation biology. And here you see that was formerly a German talk, where it's about tissue and properties and radiosensitivity of the tissues we want to irradiate. We have tolerance doses to consider of these structures and organs at risk, doses to the targets and lesions that we have to achieve to reach an intended radiation effect. we have to do those calculations and assessments from the time-dependent activity concentrations and accumulations in structures and organs. And we have to quantify that activity. We have to do that in targeted structures and in organs at risk. And finally, we have to do a clinical assessment of the treatment outcome and of the side effects, and to decide, do we do further fractions or not? Or can we do further fractions or not? For that, we mostly use computational phantoms, and back in the days, it was the stylized first generation phantoms. Then we had the second generation voxel-based computerized NURBS phantoms, as we call them. They were much more detailed and scalable. And we have many more here in this handbook of the anatomical models for radiation dosimetry. And finally, Radar developed new generation dosimetry models, and the latest publication on those things is the new MIRT primer that those of you who work with medical internal radiation dose, of course, know, and the latest version is of 2022. We have to predict the accumulated activity. Here is a little graph on how we, in terms of compartments, we imagine that. And then we have the so-called S value that most of you will be familiar with. That is actually the fraction of the energy that is transferred by a source to a target and will be absorbed by the target depending on the number of these decays, of the energy, and even that fraction. Then we have the MIRT equation, where we use the accumulated activity in a target or whatever organ at risk region to calculate the dose to the target out of that accumulated activity and the S value. We normalize that to an administered activity, and the graphic explanation of that is the residence time that is actually equaling the surface under the time integrated activity curve idealized to a square. And basically, the monitoring and verification of biokinetics and biodistribution is the basis for dose calculations that works like that we inject the activity and then we calibrate and contour our regions, and then we follow the time integrated activity curves and determine the surface and the accumulated activity under that curve. We have different options to do that. We can just use a probe, or we can use imaging that we measure our activity distribution with. That will be hampered by attenuation, detector characteristics, scatter, motion, and partial volume effect, depending on the volumes that we are interested in. Then we reconstruct and have to correct for even that: attenuation, scatter, resolution, recovery, motion correction, partial volume effect. Then we reach a measured actually event or count rate distribution, which is still not our activity distribution. And then if we have the system calibrated correctly, then we will reach a measured activity distribution. And that's actually what we are interested in. 3 and 4-dimensional, meaning the volume and the time distribution. Here's actually a graph how that should work, and we will go through this gradually now, and we have different options. So that will appear several times during the talk. We have several options. So we have a planar dosimetry, you have 2.5 or 3D dosimetry. What is meant with 2.5 will be clear later. That is hybrid or volumetric, true volumetric dosimetry, and with consideration of the time points at which we do that, we have a certain development to single time point methods, and that will actually also be mentioned in all those talks. Let's start here with the calibration and determination of the sensitivity. That means the counts per second per megabecquerel. That can be done with a known source or with a phantom. And then we determine the calibration factor. And we can, if we talk about Hermes, we have this window where we can actually decide if we had a point source or a uniform phantom, and then we will get our calibration factor. And that enables our gamma camera measurements, or even also PET measurements, where the calibration is more straightforward, to actually measure activity concentrations. If we do that on several time points over time. Here is actually just a short mention of how we calculate this factor, just for you to revisit if you want to see that later on. And then we are already with the analysis of the planar whole body scintigrams and SPECT data, depending on what we do, either 2D planar, 2.5 or 3D hybrid dosimetry. And that is actually when we consider the 2D planar, you find that always up here. The contouring of the ROIs at one time point, transfer all those ROIs to all the time points where we have our whole body scans. And after transfer, we of course have to check and if needed, adapt the ROIs to the actual position of structures and lesions or organs at risk. Just translations, no shape and size adaptations are allowed here at this moment. And if we do a 2D or 3D approach, we have CT and nuclear medicine data that we have to co-register at various time points based on volumetric structural CT and structural CT data, and also our SPECT uptake data. Then we have different options. We can choose whatever software we use. If we want to do that on our SPECT data, or rather on our structural data, meaning the CT and this hybrid option here. Here is an example for the kidney which is easy to determine its volume from the CT data, but it also can be done if the distribution is homogeneous on the SPECT data. With new reconstruction methods that come along, we can also reconstruct the data anew. We can actually use quantified data with this calibration factor that we have determined before, and then reconstruct an actual dose map that have, of course, to consider several integration approximations. And here I already mentioned the single time point method, considering the fact that not every patient will be able to be for a SPECT and scan about 30 minutes time points on the camera, or even more. It can be 4, 5, 6 time points. So we mix, and here is the explanation for 2.5 dosimetry, planar data, meaning whole body scans with at least one time point, where we have a CT and a SPECT data set. And single time point, to not confuse you, means that we have to find the time point in the time activity integration where it would be suitable to deduct the whole time activity curve. So to reduce the measuring time points. Jens has actually, based on the Henscheid method I mentioned before, compared this and actually checked the feasibility of true single time point dosimetry and PSMR targeted therapy. And you see, for a tumor, it is actually very comparable with the full dosimetry. That means with all time points, if you use one single time point at 72 hours to deduct the full time activity curves. For the organs at risk, it's about that clear, but not this clear as it is in the tumors. So just some examples for what other software tools you could use. This here is the voxel dosimetry of HMS Medical Solutions. I should mention that in a HMS Educational Series, where you can do the void drawing very, very sophisticated. You can have a 3D object, ellipsoid, quaders, or cylinders, manual drawing, segmentation on the basis of Hounsfield units or activity, thresholding on the basis of those two values. Lots of other segmentation tools, for instance, the blob splitter, where you can actually have an automatism that subdivides your region of interest into tumors and healthy tissue, for instance, in the liver, and so on. It is very, very easy to, well, maybe one very too much, but it's easy to use. And the quick pre-selection with the brush is possible, and the subsequent segmentation based on the HU units is even possible there. Here's a little practical procedure example of a of a lutetium-DOTA-TOC radioligand therapy with a metastatic net in the terminal ileum, and the liver metastases, osseous metastases, and peritoneal carcinosis, lymphogenic metastases, where we actually used the voxel dosimetry and the VOI tools of HMS to very straightforward delineate every region, meaning targets and organs at risk we are interested in. And that can be actually rendered then. It's always fancy to do that. And to show you how this also then can be done for the bones, so that you can compare that with your blood sample derived blood dosimetry. And here we are actually with the determination of the accumulated activity, and we fit time activity integrated curves if we have our measuring time points measured either with a single time point method or with more time points that we have from planar or 3D data. We assess then the time integrated activity curve in the single time point method. There is actually a assessment. Here again, kudos that we use with a very simple example of a mono exponential decay, where you actually can divide it in several parts of the curve. Yeah, how you want to integrate there. After your last measuring time point, you should actually use the decay only. But this is actually fitting tools, and there are a lot of those tools out there, and you might be wanting to choose whatever you want, but it's not about the sophistication of a tool like this. It's about the integration in the whole workflow that makes it sometimes complicated. Here you see how we would do that with a planar dosimetry with a Q-dose, where you have actually everything, every mass and every organ dimension out of an IDEC phantom, and there is a number of phantoms out there, and you need to actually choose what you want. And when you do a 2.5 hybrid, you would actually select some of the organs that you actually have measured at one time point 3D, and then use that volumes for your dosimetry, but with your activity data from planar scintigrams. So you have one 3D time point and more, as much as the patient can bear with, whole body scan. So you need only one 3D time point as a reference time point. If you have patients who can bear with more 3D time points, that's the most comfortable situation for us physicists. But that is actually very rare that you get patients on a SPECT CT system for 3 or more times. That would be one of those situations, and that is actually, I guess Jens was comparing to his single time point method, or the single time point method of Henscheid, and there are more methods like that out to determine what time point would be the best to determine the activity, to conclude from there the time integrated activity curve. And here we go with the determination of our organ doses from accumulated activities and S values. And that is actually our work equation of the medical internal radiation dose approach. Here's a report. Of course, you have to report the dosimetry, and this is actually what we derived ourselves. You have to actually self automatize that, because that what is actually out in the tools is either too extensive and contains too much data, or is even not present. So we created something by ourselves. That is actually what you see here. I hope yes, the patient name is not there. And of course, we include, as radiotherapy physicists, to do also some images on the basis of which we actually did our dosimetry, and of course those volume histograms. And it's actually the same as we know it from radiotherapy, from external beam radiotherapy, with the difference that our input data are much more complicated. It's not just structural data and the knowledge of a beam. We need to know biokinetics, biodistributions, and time integrated activity distributions. Yeah, let me compare these three approaches. The 2D planar dosimetry at least needs 4 whole body scans, which is very wearing for patients with problems to lie longer and accompanied with bone pain. You might have ROI overlap if you think of the kidneys. They can be overlapped by guts and whoever, whatever might be in the view. Organs partially or actually not identifiable, so no organ dosimetry will be possible. It's very extensive. It's a very extensive report in the end, and confuses sometimes by the level of detail. As that's what I meant with if I reported what dosimetry tools we have and what reports come out. So we self-adapted our reports to be more suitable. And with a 2D or 3D hybrid volumetric dosimetry, we still have the problem that patients have to come to the camera more often. It's also there that the reports are very extensive, and we also self-adapted the reports, and the single time point method should be the method of choice, and we are actually trying to go for it because that is more bearable for patients with problems to lie longer, and but needs a little more extensive preparation of the image data for dosimetry and a little more vigilance in actually carrying out the imaging. It is a quick semi-automated way to segment and contour, as you saw. It's only rarely implemented in dosimetry tools by now. Hermes is one who has it. And you also need to self-create your report and have by that a maximum flexibility to customize. Here's a little example, and that's actually approaching the end of the little talk that I wanted to give, where we compared cycles of a lutetium PSMA therapy, and where we actually carried out all of the 3 options of the therapies. So first, the 2.5 hybrid, where we actually for the kidneys found the 16.7 Grace dose value. If we did it with the 3D volumetric, we actually find the same, and it's that actually holds true for all the other organs at risk or the lesions. But if we did this 2D, that differs quite a bit due to reasons I mentioned before. For all those, we of course, no, not for all those, but in these patients, we actually have only done the blood dosimetry from blood samples. So I cannot show you by now a comparison to what we did image-based. Here is a little list, and I by no ways can go through this in the time I have. To just for those who want to revisit the webinar, what dosimetry tools are out now I don't claim that this is complete, and I also don't claim that this conveys every detail and every features, but I think this is the most used tools with the key features people always ask for. So a sub-summary would be that we have a broadening spectrum of molecular radiotherapy becoming available. Systematic radiotherapy, we would call it. We have an advent of more subtle methodology of planning, monitoring and verification of those therapies. We have an impressive progress in hybrid cross-modality quantitative molecular hybrid imaging, and in research settings, most of these procedures are available and implemented as well-validated tools to assess uncertainties. And that's a different story here in radiotherapy with radionuclides compared to external beam radiotherapy. The practical implementation in clinical routine settings is still difficult because it's very elaborate, and patient compliance is a complete other topic as compared to external beam radiotherapy. We need further harmonization procedures, and we will have more involvement of physiologically based pharmacokinetic parameters into radionuclide therapy dosimetry, and also will be able to employ modeling approaches and artificial intelligence approaches to optimize the time integrated activity fitting. And actually, the plan here is minimization of time points needed. And finally, the final goal would be to actually be able to predict the therapy outcome based on physiological and other input parameters before we actually apply radioactivity. For instance, the lesion and tumor shrinkage. And I gave you some little references where all these things are summarized in more detail. So the question now is, as we now know the beauty of dosimetry, what is actually the regulatory need? More scientific evidence. I will show you some very, very busy slides in the scene so that you can revisit them later. And then I actually, after that last 5 slides, will hand over to Jens, who will talk with you about what is actually the clinical purpose, the need, and the feasibility. But first, there is our directive that we know all by heart, that actually in Article 4 in definition says that radiotherapeutic means radiotherapy, including nuclear medicine for therapeutic purposes. Very general, but actually binding. Article 56, optimization, says that radiotherapeutic purposes need to be individually planned, appropriately verified, and doses to non-target volumes need to be as low as reasonably achievable. I actually wanted to add something that I heard in a dosimetry workshop recently, which was actually pertaining to target lesions where the dose needs to be as high as safely attainable. Maybe that will be a new abbreviation in further times. Most of these member states in Europe translated this directive in the actually national legislation with those or the like contextual formulations. Yeah. So, and here are some examples for EU position statements on dosimetry. There's at one hand, at the one hand left here, the ENM position paper on this particular aforementioned article of the Council Directive, where most of the therapies are listed. And then there is the EFOMP, the European Physics organizations, or European Federation of Medical Physics Organizations, where is actually a list of recommendations that actually ends up with recommendations how dosimetry should and actually must be done. National statements, here is an Italian example that is actually 3 years old now, that can serve as an example also for other countries. In the German example, that is actually not quite an example because it's not as prominent, and actually is not only limited to radiotherapy, but radionuclide dosimetry in general. Further publication work is of course out, and that is only very little exampling here because there is many more, as you will see in my last slide. The EANM dosimetry committee recommendations for particular therapies with dosimetry for lutetium labeled somatostatin receptors and PSMA targets, and also some organizational things about the accessibility of clinical dosimetry. And of course, on the American and joint stage, there is also papers out by the MIRT committee on quantitative SPECT for patient-specific dosimetry, and the guidelines joined on EANM and the MIRT committee for quantitative lutetium SPECT applied for dosimetry in radiopharmaceutical therapy. And herewith, I actually want to end. I just gave you some more reading, and here actually the history of publications with dosimetry and radionuclide therapy, and there you see it dates back very, very far. I don't know what was happening here in the 70s, but that must be another topic. So, but we have every year now, since about 20 years, about 300 publications on this topic. So it must be a beauty. And now I hand over to Jens, who will talk about what is the clinical purpose, need, and feasibility. And maybe that surprises you a little bit, but that's the plan in this webinar.
Okay, so thank you very much. I hope you can see my slides.
Yes, we do.
Okay, great, thank you. So Bernhard, very nice presentation. Thank you. And also thank you very much to Hermes for giving me the chance to participate and for the very nice introduction. And as already mentioned by Bernhard, I will try to be a bit of devil's advocate, so to say, in my presentation. And therefore, I have prepared to talk with the Deputy Medical Director of my department, Martin Heuschkel, and to include and to give a doctor's perspective on the use of dosimetry in clinical routine. So these are my disclosures. Okay, as Bernhard mentioned, the topic of dosimetry and radionuclide therapy has occupied us for decades, while initially the focus was on methodological aspects and the developments. Now that we have good methods for the implementation, the usefulness and the benefits in everyday clinical practice are increasingly being discussed, sometimes very controversially. And in the following minutes, I would therefore like to give some examples of the use of dosimetry in clinical practice in various scenarios. And the examples are chosen freely by myself, but with the aim of demonstrating the benefits or the usefulness of dosimetry in clinical routine. So then let's start with the actual topic. Here's the agenda for the next minutes. I will start on safe grounds, starting with some examples on treatment on dosimetry used in the treatment of benign thyroid diseases. I will show something about the dosimetry in the treatment of liver cancer using the well-known THERT. And then I will focus on the individualization of radionuclide therapies by dosimetries, if this is possible. I will talk a little bit about the prognosis of the treatment outcome and new challenges, since we have new therapeutic targets on the market, and then what is needed to improve the clinical use of dosimetry. So dosimetry in radioiodine therapy, we know this very well. We know that radioiodine treatment is the first application of theranostics in clinical routine. And pre-therapeutically, it all starts with a simple measurement, normally by an external probe, to identify the patient-specific uptake and the iodine kinetics. And then, as Bernhard mentioned, we need to determine the treatment volume, which is normally done by ultrasound. Then we have this well-known Marinelli formula, and also a lot of guidelines that nicely show how to perform the dosimetry in these cases of therapy. Since in this particular case, we have target doses to reach and to give a certain amount of probability to treat the disease. We have the target volume, and we have the patient-specific uptake and the effective half-life. And then we end up with an activity. And this is a very brief example of how this is used in clinical routine in my department. So this is an example of a patient suffering from hyperthyroidism due to thyroid autonomy. And when we move on, this can be clearly seen that the target dose was not achieved, as there was an accelerated excretion of the iodine during the treatment. We can see by the relatively short half-life, and therefore no sufficient therapeutic success has been achieved. And but as we saw 6 months later, there is a significant reduction of the volume, despite the relatively low dose of only 55 gray. The advantage of dosimetry in such cases is that we know from the beginning that we have an undertreatment and that a further therapy step is required. And this was carried out here. And in the second round, we then reached the desired total dose of 300 gray. And later on in the follow-up, after 1 year, we have a full therapeutic success. So this nicely showed what can be achieved when having a stable foundation of knowledge on that the dosimetry is based. Therapeutic success in radioiodine therapy is dose dependent. I think that is beyond question, but even after so many decades of use, there remains a certain uncertainty in predicting the success based on the dose. Even with the same dose achieved in the same organ, as we can see here on the left, only 17.5% are optimally treated, and almost 20% are still undertreated. So, and also 5% are overtreated, which causes a hypofunction of the thyroid. So this example nicely showed that inter-individual biological difference in the therapeutic effects are inherent versus an inadequate calculation model. So we have systematic errors in the measurement, for instance, in the determination of the volume by ultrasound. So one can assume that we have approximately 20 to 30% of uncertainty of the determination of the volume in such cases. But nevertheless, in many cases, dosimetry works in this kind of therapy. The same holds true for the treatment of liver cancers and metastasis by the selective internal radiotherapy. It started many years ago with the very disappointing XERA study that compared the radioactive treatment versus the standard treatment using sorafenib. And this study showed no survival benefits for ZERD because this was the primary endpoint and it was not met. But the study also showed a significantly better quality of life and a more favorable side effect profile with ZERD, which was quite positive. But in the end, there was no extra benefit from using ZERD. So the question was, can we do better? And based on the results of the XERA study, there was a further evaluation of the dose calculation, which was based on this well-known technetium MAA scans. And this further analysis showed that there is a significant survival benefit if there was a tumor dose higher than 100 gray. So in these cases, the median overall survival was 14 months compared to 6 months. So you see that the dosimetry that leads to the tumor dose of more than 100 gray can significantly improve the overall survival. And also in this case, dosimetry works. We know this from clinical routine, but what we don't know exactly if it is possible to have a patient selection by means of a pre-therapeutic dosimetry. So this needs to be explored in further trials. So what about the individualization of radionuclide therapies, of new radionuclide therapies like Lutathera or Pluvicto by the means of dosimetry? Well, let's start how our non-radioactive medical products are dosed. So let's take a brief look at this using cabazitaxel as an example, which is indicated for the treatment of metastatic castration-resistant prostate cancer, mainly following docetaxel-based third treatments. And we have a clearly defined dosage regime, which is, in this case, is based on the patient's body surface area as a surrogate for the volume of distribution, which is a kind of individualization of the therapy. And in the case of an impaired organ, here the liver as an excretory organ, the dose must be reduced in a standardized manner. So there's no way for the physicians or for the oncologists to use alternative treatment regimes using this medicinal product. So what about PSMA targeted therapies using Pluvicto, the lutetium PSMA ligand? And how are these approved modern radionuclide therapies are used in clinical routine? Well, and we all know this, it's the clinical drug approach. We do an initial imaging. We apply the therapy with a clearly defined activity scheme. In this case, in our department, we do a follow-up within the therapy, and we see a response. And therefore, of course, the therapy will be continued. And after the therapy, we do a final imaging to assess the late response assessment. As in this case, the therapy has worked. We see a clear radiographic response, and no toxicities have been observed. So in most of the cases, or in almost all of the cases, also this new kind of therapies are applied as the conventional approved drugs. So there is, or what studies or what suggestions are nowadays available to individualize our therapies? One of the first studies on the potential optimization of the treatment of neuroendocrine tumors, in this case with lutetium dotatate, was conducted by the group from Uppsala in 2013, and they investigated the influence of the accumulated renal dose on the number of possible therapy cycles in the treatment of neuroendocrine tumors. And they treated 200 patients with repeated cycles of 7.4 gigabecquerel, and the therapy was accompanied by a regular kidney and bone marrow dosimetry, and was stopped when the cumulative absorbed dose of the red bone marrow was greater than 2 gray, or the absorbed dose for the kidneys was greater than 23 gray. And it was shown that more than 50% of the patients tolerate more than 4 cycles, which makes it possible to further saturate the tumor dose and thus consolidate the therapy, or you have room for a re-challenge at a later time point. But however, in almost, on the other side, in almost 25% of the patients, the therapy was discontinued for the 4th cycle due to the renal dose of more than 23 gray. And in everyday clinical practice, however, all patients actually receive a full 4th cycle therapy scheme. And theoretically, even every 4th patient should develop kidney toxicity after therapy. But in clinical experience, kidney issues are an absolute rarity nowadays. And so the question remains if it is possible to generalize adequately, or to generalize an improvement of the therapy in this way. I'm also aware that There are other studies available, especially prospective studies on therapy adjustment based on renal dose. For instance, from the very, very well designed phase 2 trial from Lund and Gothenburg. But as I said, this presentation is intended to stimulate the discussion and to stimulate reflection. Knowledge of dose response relationship is of enormous importance for effective therapy, and because we have to balance the dose to organs at risk and to tumors. And in this study, also from the Uppsala group, patients with pancreatic neuroendocrine neoplasias were treated, and the individual number of cycles was determined by the maximum absorbed dose for the kidneys and bone marrow again. And as a result, a clear correlation between the accumulated dose and the reduction of the tumors was clearly shown. Especially pronounced for tumors larger than 4 centimeters. But nevertheless, some lesions showed a slight response despite a high absorbed dose, but also vice versa. And this broad spectrum of apparently tumor-specific radiosensitivity is probably related to factors such heterogeneity in binding affinity, receptor density, hypoxia, necrosis, but also due to differences in tumor volume. And this study also shows that biological factors must also be taken into account when trying to optimize treatment schemes. Knowledge, I'm really sorry. And there is another issue that needs to be addressed. This current work shows very nicely that the tumor doses decrease from cycle to cycle, and we see similar with the PSMA therapy. But what does this mean for our therapy optimization? We know a very old rule from the treatment of thyroid cancer that the first hit should be the best. Should we try to apply this also to new therapies, or should we vary the activities of several therapy cycles? Let's say we start with high activity at the beginning and then giving less over the time, so we end up with the same cumulative activity, or maybe even the other way around. So there's a lot of room for discussion, a lot of room for improvement, but also a lot of need for studies. So when discussing optimization, we have to look what options does the physicians have to optimize this therapy when using approved radiopharmaceuticals. Pluvicto is approved by the FDA and by the EMA, and has to be used with a fixed treatment regime of 7.4 gigabecquerel, 6 cycles every 6 weeks. And there are recommendations what to do in case of toxicity, but dose values are not given. So the doses applied to the tumors, doses applied to the organs at risk are not described as a parameter to take care of. And the same for Lutathera, also approved by the EMA and the FDA. It has an approved fixed treatment regime that requires the physician to administer 7.4 gigabecquerel 4 times every week. And here too, a reduction in the applied activity is envisaged if side effects occur, but only on the base of laboratory parameters. Again, dose values or dose limits are not specified here. So what are the options a physician has in this situation? The market authorizations of disapproved drugs only provide a reduction of activity, not for an increase. The criterion, as I said, is the actual toxicity, not a dose value. We have the problem of the reimbursement system, of the different reimbursement systems. For instance, in Germany, the DRG. This is something like a standard flat rate, independent of the activity applied. If we use this kind of treatment outside of the authorization, this becomes an off-label use. So it is in the personal responsibility of the doctor, and if necessary, a votum of an ethics committee is needed in this case. And at the moment, in most of the prospective studies I'm aware of, we work with standard activity regimes. But do we have evidence that a higher dose or higher activities prolong the survival of the patient? This is an example from our hospital using the opportunity of individualization of the therapy that is given by the German Medicinal Act. This was a patient with a pancreatic neuroendocrine tumors with metastasis in the liver. Normally, there's not a very good response to Lutathera therapy, but this was the only treatment option left. So we applied this kind of activity, this kind of therapy, and 7 months later, we saw a very, very nice response. So is there room for the continuation of the therapy? The kidney function looks quite nice. Also, the doses for the kidneys and the bone marrow were good. And so we continued the treatment, and again, an excellent response. But then some months later, there was a progress. Should we continue the treatment? If we look for the kidney doses, for sure we will reach the 1023 gray level with the next treatment regime. But what are the options for these patients? There is no other option. So that's why in this situation, it was out of doubt that this patient needs a further treatment. So what about the prognosis due to what about the prognosis regarding overall survival, progression-free survival? And this is a very nice study on PSMA, on evaluating PSMA targeted therapies, and from a multi-center group led in this case by Gafita from Essen. And they included 270 patients, and they came up with nomograms based on several predictors. And they had 18 pre-therapeutic clinical pathological parameters and the PSMA uptake, the pre-therapeutic PSMA uptake. And they designed a very nice tool which can be downloaded, and you enter patient relevant parameters, and then you end up with a prognosis how this patient will probably survive. So this works very well, but also in this case, no dose values are needed to give a somewhat reliable prognosis factor. So we have new challenges, we have new therapeutic targets on the way. FAPI is the new kid on the block, so to say. We no longer tackle the tumor itself, we tackle the tumor-associated fibroblasts. So what kind of doses are needed in such cases? And but these therapies or this application of this kind of therapies is already there. And from my point of view, you see the publications, and we are at the beginning of making the same mistakes again that we did when implementing DOTATOC and PSMA therapies. We start to use fixed activity schemes and cycles, but as I understood, since most of these therapies are applied as individual treatment trials, there is no room, or there is limited room for an improvement by the physicians. So this needs to be tackled, definitely. So rooms for improvement. Nowadays, this pillar model is often used to describe important prerequisites that are mutually dependent, and I will use this to show some of the areas we have to intensify our work to bring dosimetry really into clinical routine. The first is radiobiology. We know that the physical properties and the interactions trigger many biological effects that go beyond the destruction of the DNA, and that contribute significantly to the biological effect, and thus hopefully to the success of the therapies. But we need to understand this better, especially given the significantly lower dose rate compared to radiotherapy, as mentioned before. So we have to better understand the effects of low dose rates on cell death. We have to better understand the influence of local immune reactions. We have to understand the micro distribution of the dose deposition, and therefore we have to perform micro dosimetry. We have to understand the interaction with these modern kind of immunotherapies. Will there be a potential treatment booster for both? And of course, we have to optimize the treatment scheme according to the results of the radiobiological. We have to design clinical trials that really show that there is an improvement of the therapy and of the patient outcome when dosimetry is implemented. And therefore, we also need standardized reports of clearly defined clinical and also dosimetry parameters in clinical studies, also in retrospective ones, to make studies and results more comparable and to facilitate multi-center analysis. And very, very recently, there is this very important publication that tackles exactly this needs. And they also designed some recommendations, what kind of parameters, what kind of information should be published or should be made available to facilitate such analysis. The third pillar is reimbursement of dosimetry. This is a very often and very critically discussed issue, and it is also specific for several countries, for the different countries. Therefore, I will not tackle this. And the fourth pillar, in my opinion, is the simplification of dosimetry to make it available in clinical routine and to facilitate the more intensive use of dosimetry in clinical routine. So thank you very much, and yeah, hopefully there will be some minutes for a discussion.
Thank you very much to our presenters, Dr. Kurth and Professor Sattler. Yes, we are running very close to time. We will continue the session, maybe a few minutes over time if necessary. And I would like to remind the audience to submit questions via the questions chat facility. And we have actually one question coming in. So let's see. Just one moment.
Maybe I thank Jens for this nice conclusion in the end with the 4 pillars. That was actually the slide I prepared to go back on my presentation, but I don't need to do that. And I wanted to actually add into the pillar of reimbursement to include that is reimbursement, of course, then determines also how many personnel and staff resources we can put into dosimetry, right? So this is also very crucial point that is actually also conjuncting with simplification. And single time point activity, a course determination would be one thing that would be possible and is already available actually, but the tools are not simple enough as I told. So that is actually for those of the company members that are in the talk now, and I know there are some, a hint that that needs to be really implemented. There is a lot of scientific evidence out about that, but it's not simple enough to use in routine. Yeah.
Yeah, there's a few questions coming in actually along those lines, Professor Sattler. One question quite simply is what resources in terms of staffing and equipment and time is needed by a smaller non-university hospital considering to start dosimetry?
Well, resources are actually determined by two things. Is there any regulatory requirement? You have a license to deal with your radionuclides for therapy. If this license requires that you have medical physicists and a certain number of specialized nuclear medicine people to treat a certain prescribed number of patients in a certain setting of different therapies. So that's a lot of variables. It's depending on that. So if you do radioiodine and say the licensed tools, then you will be fine with a specialist. Two physicists will be fine. So one can be ill, or at least three. If you have more than this, you must have also a diagnostic department or a PET scanner. Then you need more. Right, so that is a question to directly answer, very difficult, but I tried to mention the variables that need to be considered. And another thing is there is a nice document by the IAEA on staffing levels for nuclear medicine. And there's also a kind of a key how to calculate the staffing level. But that is also actually a assessment and a guidance, and it just only works if you sensitively assess and sensitively look what is the requirement in your particular department and the availability of financial resources to employ people.
Okay, yes, we're having a few questions now coming in all at once. I'll try to pick out some here. We may not have time to go through all of them. A question now coming from Ronald Bullard. Do we do anything better than self-absorbed dose calculations for tumors? Most do only doses S times TIA. I guess he's referring to other softwares. Yeah, do either of
That's
the
actually a question for
presenters have a
Jens, I would
comment?
say. Sorry, Jens.
Oh, it's fine.
Straight away I would say no.
That's fine, and Roland exactly tackled the critical points we have, because based on this organ level dosimetry, we assume a homogeneous distribution of those, and this doesn't hold true. We know this for sure, especially for the kidneys, but also for the tumors, and we need to get rid of this. I'm convinced that we need to switch to voxel level dosimetry, but therefore we need better spatial resolutions or better methods to compensate for partial volume effects. We need better SPECT reconstructions, faster SPECT reconstructions. In the context of simplifications, I also have AI or deep learning methods in mind, also for the improvement of reconstructions and to speed up the imaging sessions. But also and especially to develop this 3D approaches in dosimetry.
Yes, actually, as I mentioned before, there's quite a bit of voxel dosimetry, of course, limited by the facts that Jens mentioned out there already, but not implemented in every tool. So, of course, we can calculate inhomogeneous dose distributions in organs or tumors. But the question is, how does that help in the future to determine what will be the outcome of the therapy? Yeah, technically it's there, but it's not simple enough to have it in routine, and is of course determined to the limits of the resolution that we have if we do imaging,
right? A few more questions now, if we have time. I realize we're going over time somewhat now.
You are
some good
the
questions coming in.
organizer.
The organ accumulated dosimetry limits are derived from external radiotherapy. There is some comment saying that this is not applicable for radionuclide therapy. What is your comment?
Well,
Yes.
we need to start out somewhere, right? So, and that if we would actually go to that level of detail, it adds more complexity, and we need to actually start out from things we know. And of course, yeah, we have photons and in external beam radiotherapy, but sometimes and most of the times we treat with particles, alphas or electrons, and that is of course not the same. But that would actually raise the question that one very, very big name in the field sometimes mentioned, the gray is physically always the gray, right? Either here in nuclear medicine or in external beam radiotherapy, the only question is how do we get to this gray, right? So yes, that's right. It's not completely applicable, but my comment would be we need to start somewhere, right? Maybe you want to add some more, and I need to actually disclose that I am not the radiobiology expert in detail, but that would be actually my small comment to that. Jens, anything more about that?
Yeah, I totally agree to you, Bernhard. But in principle, it is absolutely true that we can no longer rely on the dose limits or on the dose thresholds from external beam therapy. There are a lot of studies and also clinical experience shows that, for instance, this 23 or 28 gray level for the kidneys doesn't hold true for the radioligand therapy. We have
and the question that
in my department we have a lot of patients treated to kidney doses higher than 30 gray with no or only minor kidney toxicity.
Yes, that actually raises then the question that is completely justified, I want to mention. Either do we apply really these grays that we calculate, or is the biological effect somehow different due to the fact that we use other kinds of radiation, right?
Yeah, I think especially the much lower dose rates of milligrays per hour has a significant biological effect.
Yes, one of the things, not the only, but one of the things.
We have time for maybe one more question. There's a couple coming in, which I'm going to sort of synthesize into one question. It's about the focus on single time point dosimetry, which I think both of you mentioned as a really important way forward. There's some comments here that there are alternatives to the Hanscheid method that may be superior. Yep. Do you have any further comment on that, since this seems to be a very important way to go to minimize the imaging burden on the patient? As commercial vendors, for example, should we be considering other options than Hanscheid? Do you have any personal opinion on this area?
I would actually give Jens the first word, because the slide I had, I borrowed from him.
Yes, of course, there are other methods available, but as far as I understood the theory behind, to be honest, there's a very nice paper from Jan Tabrocke from London. Very nicely describes the theoretical backgrounds of all this single time point approach. And but as far as I understand, it's all about the estimation of the exponential, of the mono-exponential decay, and to find the right time point compared to the effective half-life, to find the right imaging time point compared to the effective half-life. Many of them, or not many of them, they all work well, but what we need for clinical routine is an approved software tool. When you will implement dosimetry in clinical routine and in decision making, you need an approved tool. You need a CE label. You need an approval by the FDA. So it's in the responsibility of the companies to bring this algorithms into software tools.
I actually wanted to add, and I fully agree to what you say, Jens, that here we are again with options to use AI for those things. We not only can use AI for image analysis, we also can use AI to actually train algorithms to predict this time point, which would be most optimal, by training those algorithms with well-acquired full dosimetry, as you compared in this one study. And so, and that actually, I understand, can also be dependent on the particular regimen that a department has. So there must be also options to customize or train their own algorithm under the setting of what patients do you have, what kind of patients do you have, what kind of gamma camera you have, how many time points you have in your training data set, and so on and so on. So that will be also very important to have tools to do that, right?
Yes, thank you. I'm going to break my own rule here. One more question about dose volume histograms we have here. What's your opinion about using dose volume histograms in clinical nuclear medicine dosimetry? I think we need some guidance for the different dose values, example D5, D90, etc. in nuclear medicine.
Yeah, that's right. That's right, and that's actually something I actually people who deliver those tools took over from what we know from external beam radiotherapy. Yeah, so that is actually also some of these comparisons that's maybe not valid yet for radiotherapy in radionuclide therapy. So I would say it's helpful, but we need ourselves to be trained on how to use that. So I cannot give maybe a completely satisfying answer, but that is actually surely a thing that should be accompanying the reporting of those of radiotherapy. Sorry if that is not maybe that what you expected as an answer, but we are also still on the way to implement that to use in clinical routine, as we have now tools that deliver those volume histograms.
Yep. Okay, I think that's all we have time for this evening, so we're going to wrap it up there. I would like once more to thank both of our presenters this evening for some really interesting presentations, and to thank the audience for the excellent questions. My apologies, we didn't get a chance to answer every single one, but I hope that we got at least something out of this. And just to reiterate that the recording will be available to all registrants to review after this session. Thank you very much, Professor Sattler and Dr. Kurth.
Thanks again for the possibility to be online for so many people today.
Okay, yeah. Thank you very much.